Hi everyone, I'm Michelle Coombs. I'm a physical therapist, and today we're going to continue our talk on vestibular rehabilitation therapy, or VRT. We're going to talk about balance and gait assessments. Now, there are many ways to assess balance and gait, but today we're just going to review some that are relevant to vestibular disorders. If you haven't watched my other video on VRT overview, I'd recommend it. It'll just give you some more insight. Now let's talk about some conditions that we often see with imbalance. Some people will have something called lateral pulsion. This is a consistent tendency to fall toward the side where their vestibular system is not working well. So we have a vestibular apparatus on either side of our inner ear, and sometimes one side will have something that's going wrong and impaired, and that will be the side that we consider is hypofunctioning. And so these people, they tend to have this happen shortly after a vestibular loss. It can last for days to weeks, but they'll have a tendency to fall toward that side where the vestibular apparatus is not working properly. We can assess this by having them stand with their feet together, so a narrow base of support, and comparing their eyes open versus eyes closed. This will give us a sense of if they can keep their posture in the middle and can they stay stable in that position, or are they already starting to fall toward one side? Now, some people, they actually fall backward. This is called retropulsion. It's not common in peripheral disorders, but it is common in central disorders, such as Parkinson's disease, white matter disorders, etc. So the retropulsion test is what we normally use. The clinician is going to stand in front of the person. They might have their hands crossed, and the clinician is going to give them a quick nudge backward, usually pushing on their hip or their pelvis. And we take a look at their balance reaction. Do they take a couple steps back and then regain their balance? Do they take a couple steps back and need help to regain their balance? Do they have no riding reaction at all? If it's really impaired, some people, they will just fall back and have no reaction to try to catch themselves. So clinicians, you do want to be ready to help them prevent a fall if that occurs. Now, retropulsion, there's also a large concern for injuries. Normally, if we fall to the side or fall forward, our hands will automatically go out to try to protect us. But if you fall backward, then it's really going to be hard. So there's a lot more injuries that happen. Let's also talk about orthostatic tremor. This is something that some people will have if they have balance deficits. It's kind of like a tremoring when they're on their feet and they're kind of, like tremoring like this, but it tends to go away when they sit down, and when they start walking, it tends to get better. We don't always know why this happens. Some people, it's because there's a cerebellar involvement. Some people, it's because of a chronic alcohol abuse. Some people, if they have a psychiatric disorder, it may be something that you see sometimes, but not others. So it's just good to be aware of. Now, let's talk a little bit about the balance assessment. This balance assessment is called the Modified Clinical Test of Sensory Interaction Imbalance. It's a mouthful, it's really long. We tend to call it the Modified CATSIB. It compares proprioception, vision, and vestibular cues that someone might use for balance. It's important to remember that this is mainly used for assessment. It's not like an outcome measure where you would repeatedly use it over time to measure progress. Now, for the modified CATSIB, there are 4 conditions. The first condition is having them stand on a firm surface with their eyes open. In this condition, they are allowed to use all 3 systems, their proprioception, their visual system, and their vestibular system for balance. The second condition, they're going to stand with firm surface with their eyes closed. So here, they can still rely on their proprioception and their vestibular cues, but we take away the visual cues. The third condition, we're usually going to have them on a compliant surface. So in the clinic, that's usually a foam pad, an Eric's pad. Those are the same thing. So they just can't use the proprioceptive cues as well. Compliant surface, eyes open, is condition 3. So they get to use their visual system and their vestibular system here. The fourth condition, they're going to be standing on a compliant surface, so the foam pad, with their eyes closed. So we're taking away proprioceptive cues, we're taking away visual cues. They only get to rely on vestibular cues to tell them where they are in space. So if someone does have a vestibular disorder, they tend to do poorly here. They may lose their balance. We tend to give them 30-second trials times 3 times. And it's been found that if they're on the foam pad, the condition 3 and 4, whether they're wearing shoes or not, whether their base of support is normal or narrow or not, it doesn't matter as much. We grade them by saying if they have min, mild, or moderate postural sway, severe postural sway. We can say they consistently fall, or they consistently have a fall reaction that requires physical intervention. So remember, if they fail condition number 4, we can't say that this means they have a vestibular impairment. What we can say is that this person does not use vestibular cues well for maintaining balance. Let's talk a little bit about a gait assessment. Now, there are many informal ways to assess gait. We can look at gait with head movement in various planes, up and down, side to side, all sorts of things like that. We can have them walk with their eyes open versus eyes closed. We can have them abruptly stop and turn around. People with vestibular issues, sometimes they're more impaired when they turn toward, again, that hypofunctioning side. And they're more stable when they turn toward the intact side. We can look at tandem gait, which is just heel to toe gait. Some people, if you see a wide base of support, it means that they either have imbalance or they have poor vision. There's some reason why they can't keep a narrow base. If some people are scissoring where their feet actually cross midline, it might be that they have some sort of cerebellar ataxia that's often seen there. We can look at gait on a compliant surface. So again, we looked at standing balance on foam. If you have a foam or padded surface they can walk on, or sand, or even a grassy terrain, it's just a surface that's not firm and predictable for them. It's important to remember if somebody has a peripheral vestibular loss, but otherwise they look pretty healthy, they tend to look pretty unsteady, but they rarely fall down. So we want to make sure that we're not overguarding them, and we let their family and friends know that, hey, they look unsteady, but sometimes the person trying to help them and putting their hands on them is actually what's going to make them lose their balance. Now let's go over briefly some outcome measures for the vestibular population. These are different outcome measures that can give us an idea of their fall risk. It can be used for goal setting. It can be used to measure their progress over time. Most of them, they're going to give a practice run and then 2 to 3 trials of the actual test, and they might average the scores. The first test is called the timed up and go, or the TUG test. In this test, it's a time test where we measure how long does it take them to stand up from a chair, walk to a target 3 meters or 10 feet away, turn around, come back, and sit fully back in the chair. So based on the time that they get, then you can compare it to the cutoff score and the normative values. For vestibular population, it would be important to compare turning to the right and turning to the left and seeing if there's a difference there. The next test is called the 5-time sit to stand test. You're sitting in a chair. Here, we want to try to have them cross their arms over their chest so they're not using their arms to push each time to stand. This test is going to take a look at their functional leg strength. It is also timed, and they're standing up fully and sitting down fully for 5 repetitions. Next test is called the Berg balance test. There are 14 items in this test. It looks at functional task balance, and it gets harder and harder and harder. So the first task is just stand up from the chair. The last task is standing on one leg. So you can see it gets harder for them. Next, we have the dynamic gait index, or the DGI. This is found to be more sensitive than the Berg balance for the vestibular population. However, there can be a ceiling effect. It looks at things like head turns, vertical as well as horizontal, pivot turns, stepping over objects, stepping around objects, doing a few stairs. But for people who are highly functioning, it tends to have a ceiling effect where it doesn't capture the impairment. So if this is the case, we can also use the functional gait assessment, or the FGA. There's less of a ceiling effect than the DGI, and it'll also look at things like tandem gait, walking backwards, walking with your eyes closed, things like that. The last test we're just going to talk about is the 4-square step test. This involves multi-directional stepping over obstacles. It's also timed, and it's just another assessment that we can look at their balance when they're changing directions. I didn't go too much into any of these outcome measures because they're pretty easy to find online. You can find PDF versions of them. You can find videos of them being done. They're often standardized without an assistive device. So if the person you're working with needs to use an assisted device, you have to document that. On some outcome measures like the DGI, if they use an assisted device, then you're not going to be able to get full score. And it's going to be difficult to fully compare that to the normative values given. Of course, depends on the setting that you're in. If you're in an outpatient setting, people might be a little more high level there. They might not need an assistive device, but of course, use your judgment. If you're in the hospital setting or an inpatient rehab, many people do need their assisted device to not fall. So if you are needing to use an assisted device, if you're needing to provide cues or provide some sort of hands-on assistance, you do need to document that so that whoever does the future reassessment, whether yourself or another clinician, they know that and they know what they're comparing to. All right, I know that was a lot, and hopefully you enjoyed the video. I'll continue to do more videos like this, and I hope you liked it. And if you did, like and subscribe. See you next time.